Oftentimes when we think of being more consumer friendly, we think of just reducing friction and making it simpler when the member decides to engage, or when the patient decides to engage. I think um, being proactive in helping them navigate, understand what resources are available when they might need more active care is the key to unlocking a feeling of this is a good consumer experience. This is more than I expected. You're not just not making me mad, you're actually helping me. And so I think that continued capacity for proactively outreaching to patients is the key.
Try to fix the current system or reimagine something new. Will healthcare ever serve consumers just like me and you? The power's in our hands, but every side's gotta come together. We want the newer generations to get something better. Until we flip the script and talk about what gets prevented. Until we see the changes permanent as if we meant it. Until healthcare is finally consumer-centered. We've got a lot to rap about.
Welcome back to the leading podcast about consumer-centered health. This is more than a show. This is a mission, y'all. As builders and operators, we're here to share with you the latest consumer-centered ways that healthcare is being designed, marketed, and delivered. And as consumers yourselves, we want you to understand how these options work and why they might be right for you and your loved ones. Here's what's going down today. First up, we have the Flava of the week about the new Samsung Health app features. How is Samsung positioning the upcoming Galaxy Watch as a proactive health partner? And how can we lead the charge to bridge the gap between healthcare and prevention? I'll talk about that. Then Mike Roaldi, president of Cityblock Health, discusses the economics of care delivery while working to better engage consumers, what's behind Cityblock's recent growth, and how he sees patients using ChatGPT for their health. I'm Jared Johnson. Let's get it. Flava of the week. Samsung believes its newest app features will transform the user experience from passive tracking to proactive guidance. On June 4th, they announced a major update to the Samsung Health app, transforming the upcoming Galaxy Watch into a proactive, intelligent health partner. According to a press release, the update makes daily health management effortless by translating complex biometric data from overnight sleep to daily activity into simple, actionable guidance. The app update comes with 4 new features. First, Vitals, which gives a better understanding of the body's signals. Previously, Samsung Health monitored specific health metrics to help measure users' daily energy score. Now, when users wake up, the new Vitals feature analyzes 5 key overnight biosignals: heart rate variability, respiratory rate, skin temperature, and blood oxygen against their true resting baseline. Second, Heart Health Score. This daily single metric takes the insights previously found in vascular load, such as sleep, stress, and activity, and combines them with body composition data. The result is a unified score that clearly identifies the habits impacting users' long-term well-being, giving them immediate clarity on their heart health. Third, Daily Cardio Load, which measures accumulated cardiovascular strain. It calculates daily load and maximum training capacity, and then recommends optimal training targets and rest times to ensure users reach their goals without risking burnout or injury. And fourth, Fitness Index. This one ensures exercise routines are working by analyzing metrics like heart rate, VO2 max, and daily steps against peers. What's the consumer lens? This could be one of the simpler ways to take proactive health to the next level. Samsung's betting that AI can turn existing biometrics into a more compelling health experience. That's exactly the same strategic direction we're seeing across consumer health, preventive care, and digital therapeutics. These new AI-powered features are designed to translate biometric signals into actionable insights. Now, we're starting to hear that from lots of different sources now, except, ironically, from your doctor. And that's why I hope providers truly pay attention here. Because if we ever want to see real progress towards a healthier society, it's time to stop talking about sick care and preventive care in silos. Let's pay attention to the ways that consumers use the Samsung Health app's new features and lead the charge to bridge the gap between healthcare and prevention. That's another way that we'll build the healthcare of tomorrow. And that's the Flava of the week. All right, everyone, let's get into the flow. Zane, welcome back. I'm hoping winter is starting to fade a little bit, but I don't think that's necessarily been the case in your part of the country.
I mean, you got to be careful here in Detroit. It's warm right now and a little bit sunny, but there's still definitely a threat of snow and ice. So I'm not getting my hopes up yet, even though I think we're technically in spring now when this interview is going to drop. So we'll see. A few more months before we can be safe.
That's right. Well, yes, that's one thing I'm learning is when I ask about the weather about this time of year to just keep that in mind. It could change at any moment. What do you hope to kind of focus on or hear from Mike on our conversation today?
Well, I know we've had Cityblock on the show before, and so I'm interested in getting an update and see where things are at. But more importantly, when I think about what Cityblock does and others and, the primary care, primary health space for, complex patients, in my mind, that's real healthcare. That's the mission field. I know we get a lot of, strictly tech innovators on this podcast. And yes, they're doing fantastic things, but I always love talking to the folks that have these new models of care that are actually doing the work and not just the ones enabling the work from behind the scenes. And so I'm interested in hearing some stories and hearing how the model's working and what's planned for the future and how models like this are going to continue to scale across the country.
All right, well, that gives us some good things to check in on. And with that, let's bring Mike onto the show. Mike, welcome to the Healthcare Wrap.
Thanks for having me.
We looked it up. It was Cameron Matthews was our guest almost exactly 2 years ago. It was in April of 2024. And I think we'll have ourselves a chance to talk through some of those evolutions and some of those things that have happened since then, to Zane's point. But yeah, Mike, let's give you a chance to share a little bit more about who you are and what you do.
Yeah, Mike Roaldi. I am president of Cityblock. I lead our growth teams, our market operations teams, and I've been here for a little over 18 months after 10 years with a large national payer. So it's been very interesting to bring the payer's perspective to a risk-based primary care company. And prior to that, I was an attorney. So don't.
Nice.
So give us a little primer on Cityblock. I think we were mentioning just off camera. We've had a good number of people start following the show since the last time that we had a guest from Cityblock on. Can you remind us of just the model in general? We talk about risk-based care here, primary care, and where have you seen that success over the recent years?
Our model is, I like to say that it was designed specifically for high-risk individuals, for Medicaid and dually eligible members who have complex needs. And I like to say it that way because it really was specifically designed that way, as opposed to, in some instances, the application of value-based care has been sort of superimposed on an existing healthcare infrastructure. Whereas we had the chance to say, if we were going to start entirely from scratch, serving a population like this, what would you need? And so that's why our services are very comprehensive. They're not as anchored to a clinic, although we do have clinics as a traditional primary care provider. But we serve, as I said, Medicaid and dually eligible members. And we are a primary care provider, but we also provide behavioral health care, provide in-home care through our mobile integrated care team. We support their pharmacy needs. We support their long-term services and supports needs, as well as social care. So it's really a comprehensive model meant to meet members if needed at a clinic, but also in a much more decentralized way and virtual where possible. And it's one that we focus wholly on our ability to drive outcomes, quality, total cost of care, and patient satisfaction.
What stands out from the experience with Cityblock patients?
One thing that stands out is just how proactive we are in engaging them. I think that's absolutely critical. Can't be with a population that has a lot of needs. You can't hope that they seek care. You have to make it as frictionless as possible, but also proactively engage them. And so what a patient or member experiences is us reaching out to them ideally through a means that they're comfortable with, and then also providing them with something that they value as quickly as possible. And we measure satisfaction in traditional ways. We look at NPS, but we also developed what we call a trust index.
Mm-hmm.
I think it's absolutely critical for the member to trust us and want to interact with us. And so we don't just look at would the the member recommend us. We look at, would the member say that they trust us?
Wow.
And I think that's really important. And it's a different strategy than just measuring NPS, because it tells you a little bit more about whether or not they're going to take our recommendations, they're going to take our next call. And so the member experiences a proactive outreach in a way that they prefer, hopefully delivering something of need to them and building trust that we can then measure.
I love that. Yeah.
I love the introduction of trust as almost like the superlative to consumer experience. Certainly in more traditional healthcare models, I think people look or leaders look at the Medicare, Medicaid population as just another segment or another channel. But you guys really take it as like, how do we actually build trust with these folks so that they, adhere to whatever care plan that we want to get them on. And I just don't think more traditional models are thinking that way. And so kudos to you all for taking it to that next step.
Thank you. Yeah, I mean, it's really been out of necessity. If you just try to get an assessment done the moment that you get somebody on the phone, or close a gap in care, or they sense that you are doing something that is beneficial for you, but might not be what they need immediately, you don't build the kind of trust necessary to get them to engage with you a year from now,
Yeah.
or to ask them to, complete a longer assessment, or whatever it is that ultimately is longitudinally going to have a bigger impact on their care. So it was a big development for us to unlock that insight of we need to develop this trusted measure.
You talked about essentially talked about like patients' preferences and how they want to be reached out to and engaged. How do you all determine that? When a patient first becomes a member of Cityblock, is there some big, assessment around preferences, or how do you figure out how folks actually want to be engaged?
Yeah, that initial engagement, we're obviously working off of a hypothesis because we haven't yet been able to determine what their preference is. And so we actually look at the data and on each member and build an individual profile for that member of their most likely time, place, modality of engagement. Uh, and so I think that's important because, historically plans might have stratified people into three groups: low risk, high risk, emerging risk, something like that. I think we've found it to be much more effective to have something more like a spectrum, an individualized profile for each member. And we're able to continually learn. Members with certain characteristics might be more open to outreach or engagement through certain means at a different time. We actually have even found that receiving a mailer can help with that initial engagement. You wouldn't think in this day and age that having a mailer would matter, but it gives a legitimacy. It reduces the scam reflex when they do get that first text message outreach or phone call. So that engagement is really initially driven by the data that we have on that member compared to the hundreds of thousands of members that we've served in the past. And then after that, obviously, we want to learn and incorporate that member's specific preferences.
I've led some primary research recently that would suggest that mailers and phone calls still work among certain segments of the population. And so I think it's important for people listening to hear that as digital as we focus on this podcast, some of those older school channels for certain segments still work and still need to be in place. Jer-
And I didn't know this, but the concept of priming is really important. They might not necessarily be the in and of themselves enough, but they might help with other means of engagement by priming those members.
Definitely.
Well, yeah, like you're saying, just kind of making it feel less scammy when they get the text to engage in another part of that process. Yeah. To that end, what are some of the biggest evolutions in your model since we did have Dr. Matthews on a couple of years ago?
Yeah, I mean, the first would be just scale. We've grown. We're probably twice the size we were 2 years ago. So very rapid growth, which enables that continuous learning cycle. So that scale has allowed for the incremental improvements in engagement as our models learn what works the best. I would also add that we've added LTSS capabilities to our model. So As the policy environment has changed to integrate the Medicaid benefit in duals, we're in a great position to serve those LTSS members, both from a primary care and home and community-based services perspective. LTSS capabilities, additional scale, and then obviously incorporation of artificial intelligence, which has, and I'm sure many of your guests have been talking about recently. So those are the big ones. Our core model is really the same. We're just continuing to improve upon it, and serving. We've grown quite a bit in duals, so that has been a change, and it's been part of the motivator for developing LTSS capabilities.
So LTSS, remind us, that's long-term services and supports.
Yes,
That's it.
apologies. Long-term services and supports, those with a primary focus on home and community-based services, which is kind of a subset of the LTSS benefit. And that's for members that would otherwise likely be in a skilled nursing facility, but because they're able to get this additional benefit at home, they're able to stay in their home. So it's non-traditional healthcare services like a personal care attendant in their home, or a home modification like a grab bar in their shower, or something that is necessary for that member to continue to live independently at home and not be admitted to a nursing facility.
Yeah, that's a big piece. We have had several conversations with guests over the years about the importance of things like that that just don't tend to show up in headlines, but that grab rod in the shower, that thing that makes a home a little bit safer, easier to get transportation to and from appointments and elsewhere in the community, a way to get healthier groceries into the home. There's some overlap there in some of the LTSS services, is kind of my understanding here. So, what has that helped you do? What problem has that helped you solve?
This is a problem I'm sure you talk about often, but we've fragmented the system in a way that if we're just looking at somebody's traditional medical needs through a primary care or even a behavioral health lens, we're not able to address everything that might be contributing to a poor outcome for that member. The great part about a home and community based service is it creates that benefit, creates the ability to address other things in that person's life that might be exacerbating their health condition. So, if a person can't be as mobile because they don't have the right walker, or they don't have a ramp leading up to their door, that might exacerbate behavioral health symptoms, or might lead to increased risk of falling. The other thing we found is sometimes members end up in a skilled nursing facility prematurely because they're afraid of an urgent event not being mobile enough to be able to seek care when they need to. And so by expanding what we're offering to those services, we can have a much more holistic look at that member and what we can do to serve them in order to control the total cost of care, improve quality, improve member experience.
I'd love to dive into the economics here for a moment of care delivery of the City Block model, as deep as you're willing to share here. But when you talk about things like, hey, we want to better engage our members, we want to better engage patients, we want them to understand their benefits, we want them to ultimately be healthier. The economics sometimes don't follow those things quite as well or quite as quickly as the desire to improve an experience or to better engage. What are the basics of the economics right now of the way you deliver care, and what needs to change to improve the way you engage consumers?
Yeah. So we have two broad categories of financial structures that we work under: risk and non-risk. And in those risk, obviously there's a lot of nuances by partner, by contract, by population. But in the risk-based models, we're at full risk, meaning if we reduce that member's total cost of care or improve their MLR, we perform well financially. And if we don't, we bear the brunt of those financial losses. On the non-risk side, oftentimes we'll work under a per member per month payment or per engaged member payment. On the risk side, obviously that frees up. We're not constrained by what are the highest value services from a fee for service perspective, and how do we retain as many of those as possible, like many traditional fee for service providers are. So we're able to make the economics work with with providers seeing fewer patients, with adding these additional resources on top of what a traditional medical practice would do, like engagement, like these systems. But obviously those add costs for us as well. So the more that we can develop systems to make sure we're reaching the right members, have some of the outreach be done by artificial intelligence, that improves our economics as well. As I said, on the non-risk side, that's usually in the form of a PMPM. We're able to drive things that in either model, we're able to drive things that really provide economic value to our health plan partners, like improving HEDIS performance, which oftentimes their revenue is tied to, like reducing readmissions, reducing the overall total cost of care, as well as helping them think through what's going to be most beneficial in a Medicare context for their sales cycle as well. So we can help drive improve financial performance on their existing population, which then in turn helps them grow and offer a better service to members.
It's fantastic. In a similar vein, curious, like more on the logistics front. So when I think about your model, so you have in-person clinics, presumably have some telehealth, things like that. How do you all work with patients to like pull them into the right area whenever it's needed? And so I would imagine there's some technology that helps, get people into the right places or bring services into the home. But how do you all think about that? And how have you optimized it both for the patient experience, but then also to do well on some of the contracts that you're aligned to? Or is it
It's a great question.
ongoing?
Yeah, no, it's a great question. I think ideally through the care planning process. So, you know, we obviously want to engage and build trust, but each member is going to get an individualized care plan, and that care plan should reflect whatever their preferences are, as well as whether they're in a position to be able to access our clinic or not, whether they're at risk of urgent events that need somebody to get there as quickly as possible. And so we we do some prompting from artificial intelligence driven prompting to make sure that the care team member that's developing the care plan has suggestions based on similar patient profiles, based on Cityblock's experience of
Sure, sure.
developing a care plan that makes sense for that member. But ultimately, what gets built into the care plan should reflect the best place of service for that member's condition.
Love it. Love that it's rooted into that care plan. I'm curious, maybe a slight personal question, Mike, but given your experience, and anyone can go look you up on LinkedIn, you came from a very significant large payer. What have you had to either unlearn or what has surprised you and shocked you as you step now into Cityblock, sort of on a different side of the pond and leading the work that you do today?
It's another great question. Probably one we need an entire podcast for,
Sure.
but I have had to, I would say, unlearn matrix management. When you're in a large organization like that, the amount of work that goes into just building consensus around decisions is surprising and at times limiting. It kind of takes your focus away from thinking about members all the time and how to better serve members and how to improve your own systems. So one thing that I think a lot of people who make the jump that I did learn is just that you can move quickly and don't need to work through those layers of a larger matrix in order to make decisions and do what's right for members and for the business.
But I've been in large organizations before where it's like the bureaucracy just creates more bureaucracy and you're just lost in a mire of lack of decision making.
Yeah, you love the steering committee for the steering committee.
Yes. Yes. I know that committee very well.
Mike, what can you tell us about where Cityblock's headed in the next 6 to 12 months, or at least where you're focusing?
Continued growth. We're super excited about our growth pipeline. So we expect to expand. We're in 11 states now. We expect to expand into new states, expand with our existing payer partners, as well as add some new ones. So just so excited every time we sign a new deal. I just think to myself, this is, 10,000, 15,000 more members that get this higher level of care. And it's a really exciting feeling. So always excited for new growth. In terms of capabilities, you're not going to be surprised to hear me say artificial intelligence. Just incredibly excited about what it could mean in terms of reducing scarcity for medical care. And we have a full sort of member journey mapped with the enhancements to the member experience, as well as just additional capacity for serving traditionally underserved populations because of these capabilities. So two things I'm most excited about are just continuing to grow and serve more members with this model, and then enhancing the quality for every member through the application of our artificial intelligence.
Curious if some of your patients are using LLMs, ChatGPTs of the world to empower themselves in their care, and are your providers coming across any of this?
We're definitely seeing that, folks folks asking ChatGPT
Yeah,
I do it.
I do it. I do it. Yeah.
It's good to know. It's good to get more context. So definitely in the direct patient care, but I think that the near term opportunity is in the care navigation component.
Totally.
Even, I recently listened to our agent field a call from a member who was deeply frustrated about something that had happened. And that agent responded with empathy, did not, respond with the same frustration that a normal call center person might, or a care navigator might, given the sort of frustration level that the person was expressing, but just the composure and then the capability to get that member to the right place. So even I think those that aren't regularly interacting with artificial intelligence for the purposes of healthcare, as they encounter it in situations like that, I think you're going to see them have more interest in doing it because they have a positive experience.
I think so too. And, on the podcast, we take the perspective that it's probably a good thing that patients have access to these tools just to be more engaged in their care, learn more, understand what's going on. And it's up to providers to, kind of meet them there. And so I think it'll be interesting to see where things go.
Yes, we're definitely leaning into that. I think there's been some skepticism in some circles, but we're seeing enormous benefits so far.
Good to hear.
Lily. Yeah. Mike, last question for you is what we've been asking recently is what's one thing that can be done to make healthcare more consumer centered? I think from your perspective, when we're looking at primary care providers and just any models that are leading to the delivery of that care, what's something we can focus on to make healthcare more consumer centered?
I think it's proactive outreach. I think that the most consumer centric companies, it's a cliche at this point, but deliver what the consumer doesn't know they need yet. Oftentimes when we think of being more consumer friendly, we think of just reducing friction and making it simpler when the member decides to engage, or when the patient decides to engage. I think being proactive in helping them navigate, understand what resources are available when they might need more active care is the key to unlocking a feeling of this is a good consumer experience. This is more than I expected. You're not just not making me mad, you're actually helping me. And so I think that continued capacity for proactively outreaching to patients is the key.
That's the standard in healthcare. Just don't make me worse off, or don't make me mad.
It's a place to start anyway.
Yes, definitely.
Love that. Mike, thanks for giving us some insights here, for sharing your successes, and we wish you all the best in continuing to make healthcare consumer-centered for your members and for others in some of these new growth areas as you continue to expand across the country. But thanks for joining us today.
Likewise, I enjoyed it.